Hello everyone, today we'll discuss acute bacterial meningitis in children. Your learning objectives for this topic would be definition, risk factors, we'll see which group is at risk for developing bacterial meningitis, causative organisms in different age, pathogenesis, clinical presentation, diagnosis, differential diagnosis and management. Why we need to know about the bacterial meningitis, why it is so important in children. Bacterial meningitis is one of the most potentially serious infections occurring in infants and young children. The infection is associated with high rate of acute complications and risk of long-term morbidities. The incidence is sufficiently high in febrile patients. Well, you know all about the anatomy of brain. I don't have to tell you. Meninges is the protective covering of brain. It covers whole of brain and spinal cord. So what is meningitis? Meningitis is infection or inflammation of meninges. What are the risk factors for developing meningitis? First one is it is very common in young infants and children. And why so? Because their immune mechanisms are not well developed. Immunocompromised host. In this we have immunodeficiency, specific host defense defects as a result of altered immunoglobulin production in response to encapsulated pathogens, defects in complement system and defects in properdin system. Malignancy, immunosuppressive drugs. Here you can see in malignancy and immunosuppressive drugs, say for example in chemotherapy, we have defect in T lymphocyte function and therefore these hosts are immunocompromised and they are very prone for developing bacterial meningitis. Splenic dysfunction. In splenic dysfunction, very commonly we see is sickle cell anemia patients. And the second one is asplenia, which can be either traumatic or congenital defect. Recent colonization. That means you have a recent infection with the causative organism for acute bacterial meningitis. Close contact. What can be a close contact? That means you have come in contact with individuals who are having the disease of from the organism which is causing the meningitis. In close contact we can have household persons. It can be a maid, it can be other members of the family. Very commonly seen in daycare centers, school and college dormitories. And the other reason for close contact is crowding and poverty, which is very commonly seen in our country. Congenital or acquired CSF leak. Here we can have cranial or midline facial defects, middle or inner ear infections or ear fistulas, fracture base of skull, lumbosacral dermal sinus and meningomyelocele. CSF shunt infections. The patient may be having shunt in situ and infection of that shunt may lead to meningitis in this kind of patients. For newborns, the risk factors are prematurity, low birth weight, complicated labor, premature rupture of membranes, maternal sepsis, artificial respiration and intensive care for prolonged period. Now coming on to causative organisms. We have divided it into three below 1 month. That is, in newborn period, the common organisms for meningitis are E. coli, Streptococcus pneumoniae, Salmonella species, Pseudomonas aeruginosa, S. faecalis and Staphylococcus. Between 1 month and 3 years, the common organisms which are seen are meningococci, pneumococci and H influenza. Nowadays, we have started vaccination against H influenza, that is, HIB is being included in a national schedule. So the infections which are caused by H influenza have decreased. And beyond 3 years of age, the common organisms which are seen are meningococci and pneumococci. Now, if we look at risk patient and causative organisms, meningococcus is most commonly seen in patients who are immunodeficient. H influenza is commonly seen in patients who are having splenic dysfunction or asthenia. It can be traumatic as well as a congenital defect. Pneumococcal infection is commonly seen in patients who are having congenital or acquired CSF leak. You can see this in patients with cochlear implants also. If we look at other diagnoses like lumbosacral dermal sinus, meningomyelocele, these are commonly associated with meningitis, which is caused by organisms like staphylococcus, anaerobic organisms, and gram-negative infections. In CNS shunt infections, the common causative organisms are staphylococcus and low virulence bacteria that colonizes the skin. Now coming on to pathogenesis. What basically happens here? Well, the bacteria gain access in our body. It colonizes somewhere in the body. It can be near to your CNS or it can be in a distant place. The common site for colonization is nasopharynx. Once it has colonized in your body, it causes penetration of mucosal membrane. Now, with penetration of mucosal membrane, the bacteria will gain access in your blood and it will cause bacteremia. And the other thing which can happen is a focal infection close to CNS. Okay? It can involve places like nasopharynx, your ear, otitis media can occur, mastoiditis can occur. So these are the places from where it can directly invade the CNS. The common form of dissemination of bacteria to CNS is hematogenous route. And through hematogenous route, if bacteria has gained access into your CNS, then it will go and multiply in your subarachnoid space. Okay, from subarachnoid space, why there is so much proliferation of organisms here? Because the CSF concentration of complement and antibody are inadequate to contain the bacterial proliferation. And once the bacteria has gained access into your subarachnoid space, bacterial cell wall protein stimulates a marked inflammatory response and local production of tumor necrosis factor, interleukins, prostaglandin E, and other inflammatory mediators. And the subsequent response which we get is, the first arrow you'll see is of glial stimulation or toxicity. It will cause neuronal injury and ultimately it will lead to cytotoxic edema. The second arrow which you are seeing is leukocyte invasion, or you can say neutrophilic infiltration. It will cause the vascular thrombosis or vasculitis can occur, ischemia, and ultimately leading to cytotoxic edema. The third thing which we are seeing is increased CSF outflow resistance. Why this occurs? Because of exudates which are going and collecting into the basal spaces. This will cause increased CSF outflow resistance and hence it will cause interstitial edema. And the third thing which we see is increased barrier permeability, and this will lead to vasogenic edema. Brain injury which occurs is not simply caused by bacteria but occurs as a consequence of host reaction to inflammatory cascade. So this is the pathogenesis which is occurring in brain, and with this you will get the clinical features. Now coming on to clinical features, Well, we have different set of features in very younger infants and in older children. So we'll go stepwise. In infants, these are the clinical features which we'll see. The prominent one is fever. If the child is very sick, you can get cold hands and feet as well. Refusal to feed or vomiting is the second common feature. The child will be very irritable and dislike to be handled. Child can be drowsy, floppy or unresponsive. Rapid breathing and grunting can be seen in very sick infants. Pale blotchy skin, spots or rash can be seen in children who are very sick. Unusual cry or moaning, or you can observe a shrill cry in infants who are having meningitis. Tense or bulging fontanelle can be appreciated in whom your anterior fontanelle is open. Stiff neck or arching of back or posturing can be seen in infants, but in very younger children you will not be able to appreciate the signs of meningeal irritation. Well, a very small child cannot complain of photophobia, but he'll show dislike to bright objects or bright lights. Convulsions and seizures can be seen in younger infants. Other features which we can see are bulging fontanelle, seizures. Neurological deficits can occur. It can be motor deficit as well as cranial nerve deficits. Presence of sepsis. Well, in very young infants, we can't appreciate the signs of meningeal irritation. That is why the presence of sepsis is very important indicator in these children to say they might be having meningitis if they are showing any of the CNS signs. Coming on to clinical features in older children. Fever is a prominent feature. Vomiting will occur, which can be projectile. They can complain of severe headache as a result of raised intracranial tension. Stiff neck or the neck rigidity, which are the sign of meningeal irritation, can be appreciated in older children. Dislike to bright objects, or we can say photophobia. They'll simply complain that they are having photophobia. The child can be very drowsy or sleepy, vacant or difficult to wake. Confused and delirium can be seen in early stages of meningitis. Rashes can be appreciated in some children. Seizures can also be seen in older children. Well, other clinical features which we'll see in older children are Kernic's and Rudensky's sign. Well, these are the signs which we see in our clinical examination. I'll explain you about Kernic's and Rudensky's sign in further slides. Fundus can be normal. They can show congestion and even papilledema can be seen as a result of increased intracranial tension. Extrinsic ocular palsy can be seen. You can appreciate an squint, ptosis or diplopia. Take cerebral. When you stroke the skin of abdomen with a blunt object, you'll see a raised erythematous line in abdomen, that is known as take cerebral, which is seen in patients with meningitis. Power is usually preserved. Reflexes can be normal, exaggerated or diminished. Neurological deficits can be appreciated. You can see the motor deficits like hemiplegia and all. Cranial nerve deficits can be appreciated. Now coming on to what is Kernic's and Rudensky's sign. Well, this is Kernic's sign. Here you flex the thigh over your abdomen at 90 degrees and you try to extend at knee. The extension of knee is restricted beyond 135 degrees or the child will tell he is having pain in the hamstrings. That is a very typical sign which is seen in meningitis, and this occurs because of meningeal irritation. This is Rudensky's sign. If you flex the neck of the child, your lower limbs will be flexed This is known as Brudensky's neck sign. One more sign is there which is known as Brudensky's leg sign. In this, when you are doing Koenig's sign, the child will flex the other leg. That is Brudensky's leg sign. Brudensky's sign is having two parts. One is neck and the other one is leg sign. So both you can appreciate in patients with meningitis, and both these signs are because of meningeal irritation. While this is a normal fundus which you appreciate in a normal person, this is showing papilledema. The blood margins can be seen. This is take cerebral. When you stroke the skin of abdomen with a blunt object, you will see a raised erythematous line. This is also very specifically seen in patients with meningitis. Now coming on to special features which we can see in various organisms. First we'll see meningococcal meningitis. Well, meningococcal meningitis usually occur in patients who are immunodeficient. So here the meningitis is acute fulminating type. Petechial hemorrhages, as you can see in the picture, can be appreciated in these patients. Waterhouse-Friderichsen syndrome can also be seen in meningococcal meningitis, and it includes adrenal insufficiency, hemorrhage and necrosis of adrenal glands, which will lead to hypotension, shock, coma, and ultimately death. Other special features which can be seen in specific meningitis are in H. influenza, we'll see subdural effusion is quite common. Seizures are also very common. Residual auditory deficit. Here the basic auditory deficit which we see is the sensory neural deficit. In pneumococcal meningitis, we can see exudate, subdural effusion, and again residual auditory deficit is seen in patients with pneumococcal meningitis, which is as high as 30%. In staphylococcal meningitis, you can appreciate associated findings of umbilical sepsis, pyoderma, and septicemia. Coming on to complications which can be seen in patients with meningitis, we'll see stepwise. First, we are seeing CNS complications which can occur. Well, the first things which are seen as clinical features also are seizures, raised intracranial pressure, cranial nerve palsies, and stroke. Thrombosis of dural venous sinuses, cerebral or cerebellar herniation can also be seen if there is lot of or raised intracranial pressure. Subdural effusion or empyema can be seen, ventriculitis, arachnoiditis, brain abscess, and hydrocephalus. Well, this is a CT scan which is showing subdural effusion. You can see at the bony margins the black space which is seen. The arrow is made there. This is a scan showing subdural effusion. Here you can appreciate dilated ventricles, that is hydrocephalus can be seen, and in the lower where arrow is there, you can appreciate a lot of exudate is present there. This is one scan which is showing ventriculitis, the lining of ventricles. You can see the whiter margins. This is again suggesting ventriculitis. Here the arrow shows brain abscess. These are some common findings which can be appreciated on CT scan in a patient with bacterial meningitis. Systemic complications are shock, myocarditis, status epilepticus, SIADH. Long-term neurological deficits which can be present once the patient has improved and you have discharged the patient. The things which are left behind with the patient are hemiplegia, aphasia, ocular palsies, blindness, sensory neural hearing deficit, mental retardation. Now we look how we are going to diagnose a patient with meningitis. Well, the clinical features say by itself that you are dealing with a patient with CNS infection, commonly being meningitis. For confirmation, you do CSF analysis. What you'll see in CSF analysis, you'll see elevated pressure, turbid appearance, elevated cell count, which can be in thousands, and polymorphs are the common things which you'll see in initial stages, which can be replaced by lymphocytes if you are doing CSF in later stages of meningitis. Elevated proteins can be seen more than 100 milligrams per deciliter. Reduced sugar below 50% of blood sugar levels or less than 40 milligrams per deciliter. And therefore here, concomitant or before performing the LP, you should have a blood sugar tested. Say if the blood sugar is coming 100 and your CSF sugar is coming 40, that is below 50% of the blood sugar levels, then it becomes significant. But if your blood sugar levels are 70 and you are getting CSF sugar levels 40, that is not below 50% of the blood sugar levels. So that is why it is not significant, and therefore it is recommended to do a blood sugar prior to doing the LP. Smear and culture can be sent from the CSF sample which you have taken. Rapid diagnostic tests are there to differentiate between the viral, bacterial and tubercular meningitis, and this is based on antigen antibody detection. The common rapid tests which can be used are latex particle agglutination, ELISA and PCR. Non-specific tests which can be asked for are CRP, LDH, CSF lactic acid levels and CT scan. Differentiate diagnosis of meningitis. You have to differentiate what CNS infection you are dealing with, because your treatment will depend on the exact diagnosis which you are getting. If you treat a viral meningitis or tubercular meningitis with antibiotics, your patient will not show improvement, and therefore you need to know that you are dealing with acute bacterial meningitis. Following are the differential diagnoses which you have to make in patients with bacterial meningitis. Meningismus. Here you get the signs of meningeal irritation, but the other findings of meningitis are not present. Okay. Partially treated bacterial meningitis. In these patients, the patient would have gone to some doctor in very initial stage, and the doctor would have started antibiotics for this patient. The patient would have improved of fever and hence the antibiotics are stopped. So this meningitis is partially treated. You have not treated it to the full extent. So when the patient will again come to you with symptoms and you do the CSF analysis, you will not get the exact picture of bacterial meningitis, but you have to complete the treatment. So you have to differentiate whether you are dealing with a patient with partially treated bacterial meningitis, because CSF is not going to show you the typical features of bacterial meningitis. Aseptic meningitis. Here you get all the signs of meningitis, but your CSF is sterile. That is aseptic meningitis. You have to differentiate it from tubercular meningitis, because the line of management of a bacterial and tubercular meningitis is very different. Cryptococcal meningitis is usually seen in immunocompromised patient and you have to treat it likewise. Viral encephalitis has to be differentiated from bacterial meningitis because the line of management in both of them are different. Subarachnoid hemorrhage. Now coming on to treatment. Before getting all the results of your CSF analysis, blood test and everything, still you have to start on some medications. This is the empiric therapy. You are suspecting the child is having meningitis, but you have not confirmed yet. You have to start medications. So what you will start? Cephalosporins, we usually use the third generation cephalosporin. The commonly used drugs are ceftriaxone and cefotaxime. The dosage of these antibiotics for meningitis is quite high. So if you are giving ceftriaxone, you have to give 100 to 150 milligrams per kg per day. For Taxim, you can give 150 milligrams to 200 milligrams per kg per day. This dosage are little bit higher for what we use for other infections. Other combination which can be tried are ampicillin plus chloramphenicol. Ampicillin is also given in a higher dose of 200 milligrams per kg per day, and chloramphenicol at the dose of 100 milligrams per kg per day. And the usual duration of antibiotic therapy is 10 to 14 days. You have to give the antibiotics for 10 to 14 days even if your patient has improved of symptoms. Once you have confirmed that you are dealing with a patient with bacterial meningitis. This is specific antimicrobial therapy for specific organisms. You will see the duration of treatment for specific organisms also. Say for example in meningococci and pneumococci, the preferred antibiotics are penicillin, or you can use cephalosporins third generation, and the duration of treatment is for 7 days. But when you are not able to specify the meningitis is because of which organism, you have to give the treatment for 10 to 14 days. In H influenza, drugs which can be used are cephalosporins, ampicillin plus chloramphenicol, and duration of treatment is for 7 to 10 days. In staphylococcal infection, the preferred drug is vancomycin. You can add rifampicin, and duration of treatment is for 3 to 6 weeks. In staphylococcal meningitis, we have to make a proper diagnosis, and if you are not treating it for adequate duration, then the patient will be left behind with so many neurological complications. That is why we have to give appropriate treatment for adequate duration. For Pseudomonas, we can use ceftazidime plus an aminoglycoside, and the usual duration is for 1 to 2 weeks. For gram-negative rods, you can use cephalosporins, ampicillin plus aminoglycoside can be used, and the duration is for 3 weeks. Other additional things which we give are steroid therapy. The common steroid which is given is dexamethasone at a dose of 0.15 milligrams per kg every 6 hours for 2 to 4 days. And very important is first dose should precede antibiotics. It reduces the incidence of residual neurological deficit. Why we precede the first dose before antibiotics? This is because when we give antibiotics, a lot of inflammatory cascade or response is occurring, which is damaging our brain, and with this inflammatory response, our body is also responding to these things. To make a halt at this inflammatory response, steroid is given prior to antibiotic, and this will reduce the incidence of reduced neurological deficit, because that will reduce the inflammatory cascade which is occurring and which is damaging the brain more and more. Symptomatic therapy for intracranial pressure, we can use mannitol or 3% saline can be given. For convulsions, you have to give anticonvulsants. The commonly used drugs are phenytoin, valproate. Even phenobarb can be used in very younger patients. Fluid and electrolyte homeostasis has to be maintained. For hypotension, adequate fluid therapy plus inotropes if required has to be administered. Proper nursing care has to be given to the patients who are comatose. Treatment of complications, say for subdural empyema, if that is causing too much of problem, then you have to drain it. For hydrocephalus, the commonly seen is communicating hydrocephalus. It resolves on its own but if it is not resolving and causing a lot of CNS symptoms, then maybe in few patients BP shunt is required. Coming on to prognosis. With appropriate antibiotic therapy and supportive care, the mortality is reduced to less than 10%. Highest mortality rates are observed with pneumococcal meningitis. Severe neurodevelopmental sequelae is seen in 10 to 20% of patients. 50% may have certain neurobehavioral morbidity, and prognosis is poorest for infants below 6 months of age. Those with prolonged seizures, coma, or focal neurological signs on presentation have increased risk of long-term sequelae. However, no correlation is noted between the duration of symptoms before the diagnosis and outcome. This finishes my lecture. The important thing which you have to do is recognize the symptoms, because adequately treated, you can prevent long-term neurological sequelae. Thank you.